of a 20-something receptionist or a doctor at an STD clinic.
But eventually, the pain or the relentless itching or the sheer anxiety gets too great, and they can't use the black tape anymore. They finally drive to the clinic.
Right?
And this leads to another absolutely fascinating twist in the Hopkins data. It's a phenomenon we can call the non-STI misdirection.
This is where the biology of aging intersects directly with the psychology of fear. If you spend time looking at the literature review in Table 4 of the Hopkins paper, a very clear pattern emerges.
What's the pattern?
Time and again, older patients finally arrive at the clinic utterly terrified. They are convinced, because of their recent behavior, that they've contracted a horrifying sexually transmitted infection. But after the doctors do a full swab and blood workup, they are diagnosed with non-STI conditions that mimic the symptoms of STIs perfectly.
What kind of non-STI conditions are we talking about here?
The study lists specific examples that are vital for clinicians to understand. They frequently see conditions like lichen sclerosis, which is a chronic inflammatory skin condition that causes thin, white, patchy skin, often entirely localized on the genitals, and it causes severe itching and pain.
Ouch.
They also frequently diagnose balanitis, which is an acute inflammation of the head of the penis, often caused by poor hygiene or an overgrowth of normal skin bacteria, not a transmitted pathogen.
It sounds exactly like a herpes outbreak or syphilis sore if you don't know what you're looking at.
Exactly. They also highlight candida vaginitis, which is simply a severe yeast infection, and genital eczema. But perhaps the most common and most misdiagnosed misdirection in older women is a condition called atrophic vaginitis.
Let's stop there because that term gets thrown around in medical literature, but what exactly is atrophic vaginitis mechanically doing to the body?
It is a direct result of menopause. As women age and go through menopause, their bodies stop producing high levels of estrogen. Estrogen is the hormone responsible for keeping the tissues of the vagina thick, elastic, and well lubricated.
Okay.
When estrogen levels plummet, those tissues undergo atrophy. They become significantly thinner, much drier, and highly susceptible to micro tears and inflammation. This is atrophic vaginitis. It can cause intense itching, a burning sensation during urination, and significant pain during sexual intercourse.
Wait, burning during urination and pain during sex, those are the exact textbook symptoms of chlamydia or gonorrhea.
Precisely. To the untrained eye of an older patient who recently had unprotected sex and is currently terrified, the symptoms of atrophic vaginitis are virtually indistinguishable from a classic STI.
That's awful.
It sends them into a spiral of anxiety and shame. What feels exactly like a dangerous infection might just be the natural hormonal aging of their genital tissues.
So they go to the STD clinic for an STI they don't have, but there's an irony here, right? A clinical silver lining.
Oh, there's a massive silver lining. These highly uncomfortable non-STI conditions serve as the ultimate catalyst.
How so?
The physical discomfort of the atrophic vaginitis or the lichen sclerosis becomes so unbearable that it finally overrides their profound embarrassment. It pushes them out the door and into the clinic.
Oh, I see.
And once they're physically sitting in the exam room, the doctors can easily treat the eczema or prescribe an estrogen cream for the atrophy. But while they are there, the doctors also run this standard panel. And that is when they catch the completely silent, asymptomatic STIs we talked about earlier. They catch the late-stage syphilis that has been hiding for 20 years. They catch the new HIV infection before it destroys the immune system.
It's like accidentally going to the dentist because you are convinced you have a massive rotting cavity because your gums hurt.
Yes.
It turns out you just brushed way too hard and irritated your gums. But while you're sitting in the chair, the dentist does an x-ray and finds a totally silent, early-stage oral cancer. You never would have gone in for the screening if you hadn't irritated your gums.
That is the perfect analogy. But while it's a fortunate accident, it also highlights a massive, glaring failure in routine primary care.
Why are they bypassing their normal doctors?
Exactly. Why are these patients ending up terrified in an urban STD clinic for simple genital eczema or routine menopause-related atrophy? They are bypassing their normal doctors because their primary care doctors are fundamentally failing to ask them about their sexual health, and the patients are far too embarrassed to bring up genital itching during a routine cholesterol check.
So they just assume the worst.
They assume the absolute worst, and they seek out specialized, often anonymous clinics.
Which brings us to the ultimate reckoning of this entire deep dive. Everything we've uncovered today points to a system failure.
A complete system failure.
We've established that older adults have incredibly high rates of risky behavior, they have a massive condom gap, they delay seeking treatment for weeks out of paralyzing shame, and they confuse the normal biological aging process with STIs. Given all of that, the entire medical system needs a massive, fundamental reboot in how it handles the aging population.
The current medical system is operating on deeply entrenched, outdated stereotypes. And those stereotypes are no longer just sociological annoyances. They are actively, measurably harming patients.
I want to get highly critical of the medical system for a minute here because there's a shocking revelation buried right in the dry methodology section of the Hopkins study.
The testing protocols.
Yes. It's a systemic blind spot that absolutely blew my mind when I read it. Remember how we spent a lot of time discussing the overall acute STI prevalence for older patients, and we established it was 18.1%.
Right.
Well, the researchers admit that number is likely artificially low. Why? Because the study explicitly states that women over 50 in these Baltimore clinics were not even routinely tested for chlamydia due to budget constraints.
It is a phenomenal, almost unbelievable oversight and care. But you have to understand the brutal economics of public health.
How does that justify it?
In a publicly funded clinic with highly limited resources, directors have to triage their budgets. And the public health algorithms, driven by the macro CDC data we discussed at the very beginning, told those clinic directors, chlamydia is exclusively a young person's disease. Therefore, take your expensive PCR amplification testing budget and allocate it entirely to the 15 to 24-year-olds.
Before you go on, what is PCR testing and why is it so expensive that they have to ration it like that?
PCR stands for polymerase chain reaction. It's a highly advanced molecular test. Instead of just looking under a microscope, PCR takes a tiny microscopic fragment of the bacteria's DNA from a swab and essentially photocopies it millions of times until it's large enough for the machine to detect.
Okay, that sounds incredibly accurate.
It is incredibly accurate, especially for asymptomatic infections. But the chemical reagents and the laboratory machines required to run it are very expensive compared to a simple culture.
So they created a protocol to save money.
Yes. So the clinic instituted a protocol. Asymptomatic women over 30 were generally only given the expensive PCR swab if they specifically complained of symptoms. And women over 50 were either just treated empirically with a gas or skipped entirely for that specific, highly accurate swab.
They literally designed the diagnostic testing protocol around the unscientific assumption that older women aren't at risk. But as we just spent the last hour proving with behavioral data, they are absolutely at risk. They're having sex, they aren't using condoms, and they are acquiring HIV.
And this methodology revelation connects right back to the national CDC data, creating a terrifying paradox.
Oh, I see where this is going.
Remember the CBS News report. The national chlamydia rates for women over 55 are reported as statistically negligible. For example, the CDC notes it's something like 2.5 cases per 100,000 for women over 65. But the Baltimore study's budget constraints imply a massive flaw in that data.
They aren't testing them nationally either.
Right. Are those national estimates artificially low precisely because clinics everywhere operate on the exact same budget algorithms? Do they all assume older women aren't at risk and therefore simply stop testing them?
You cannot find what you do not look for. It's a self-fulfilling prophecy of public health data. If you refuse to run a PCR test on a 65-year-old woman for chlamydia, the infection rate for 65-year-old women stays at mathematically 0.
Exactly.
And next year, the bean counters look at that 0, and it justifies not funding tests for the next 65-year-old woman. It's a loop of willful ignorance.
It is a catastrophic loop if we connect this to the bigger picture. This is where the individual healthcare provider's responsibility has to radically shift. Doctors, nurses, and physician assistants need to stop looking at gray hair and automatically assuming asexuality.
Yes.
It borders on clinical malpractice to ignore the sexual health of a senior citizen simply because the conversation is mildly awkward. Providers must force themselves to ask the uncomfortable questions.
How should they ask it?
When a 65-year-old widow comes in for an annual physical or a blood pressure check, the doctor needs to look her in the eye and ask, are you sexually active? Are you using barrier protection? Have you had any new partners recently?
And they need to ask it with the exact same flat, clinical neutrality they use when asking a 20-year-old. Because if the doctor acts embarrassed or apologizes for asking, the patient will instantly absorb that embarrassment and lie to them.
The clinical neutrality is essential. But the responsibility doesn't stop with the doctors. We also need to rethink our public health campaigns from the ground up. As we discussed, current sexual health education is almost exclusively aimed at the youth demographic. You see giant bowls of free condoms at college health centers and brightly colored STI testing posters in high school nurses' offices.
Where are the posters in the retirement communities? Why aren't there free condoms at the bingo hall?
The Hopkins study explicitly suggests that campaigns need to be rigorously targeted. We need STI awareness campaigns deployed in the specific venues frequented by older patients.
Like doctors' offices.
Yes, that means placing educational literature in the waiting rooms of cardiologists and rheumatologists. That means running frank, unashamed educational sessions at senior centers. It means buying ad space in AARP newsletters and pinning notices on retirement community bulletin boards. We need to completely normalize the biological fact that safe sex doesn't magically end at menopause or the day you collect your first pension check.
Okay, let's take a breath and summarize the incredible journey we've been on today. We started by zooming way out, looking at a staggering national epidemic of 110 million concurrent STIs, costing the system $16 billion a year. We saw how the national narrative and the funding focuses intensely on the 15 to 24 youth demographic.
Right.
But then we took a microscope to the urban clinics of Baltimore, Maryland.
And under that microscope, we discovered a completely hidden frontier. We found older adults engaging in highly active sexual lives, completely abandoning condoms at a staggering rate of 32.6%, and unwittingly fueling a surge in late-stage syphilis and brand-new HIV diagnoses.
We watched the traditional public health predictors of risk, like race, completely dissolve in the older demographic, proving that age and the individual behavioral choices we make as we age levels the playing field in totally unexpected ways.
It was a massive revelation.
We saw patients hiding their painful symptoms for weeks out of paralyzing embarrassment, and we uncovered a medical system that is so blinded by ageist stereotypes that it literally stops running tests on them to save a few bucks.
The Johns Hopkins data completely breaks the standard textbook models of who is at risk. It demands that we rewrite the curriculum on geriatric care to include a robust, realistic, and highly scientific chapter on ongoing sexual health.
And that leads me to a final provocative thought for you to mull over as we wrap up this deep dive. We are looking at a world where the global population is aging more rapidly than at any point in human history.
Very true.
Lifespans are extending due to medical technology. The baby boomer generation is massive, and they are completely redefining what it means to be a senior citizen. Our entire medical system is going to have to deal with a massive demographic of highly active, longer-living seniors for decades to come.
The demographic wave is already crashing on the shores of our healthcare system.
So here is the question you have to ask yourself. If we are currently this blind, if we are this constrained by outdated stereotypes when it comes to something as fundamental as their sexual health, what other massive medical assumptions are we making about old age that are completely detached from the reality of how people are actually living their lives today?
That's a chilling thought.
Are we misdiagnosing their mental health, their physical capabilities, their nutritional needs, simply because we are viewing them through the dusty, outdated lens of how we thought about 70-year-olds 50 years ago?
That is the ultimate danger of letting societal assumptions and personal discomfort dictate medical practice. The data is always there, waiting to tell us the truth, if we just have the courage to look at it without prejudice.
Thank you so much for joining us on this deep dive. Stay curious, keep questioning the data, and we will see you next time.